Prof, by the way, from the next month, there's Dr. Shafira that will replace Ayesha because Ayesha now will have another agenda. So for the next month, Dr. Shafira will help us to organize the event, yeah, Prof.
Well, thank you, Shafira. That will be terrific. And Aisha, thank you for all of your help.
Thank you so much, Prof.
Yeah.
I'm glad.
Dr. Anggun, maybe usually we start at 3 or 5 minutes past 7.
Kenapa di
So
Zoom kayak
to
Dr. Dwi
let
banget ya?
more people to coming in, maybe we can start in 3
Apa lagi
minutes.
ya,
Is it okay, Dr. Anggun and Prof. Chandra?
Yeah, no problems. I'm free.
Thank
I have
you.
nothing else to do.
And Dr. Anggun, usually we start with the case presentation first and then the lecture. Thank you.
Okay, thank you, Dr. Mita. Good evening, everyone. Good evening, Prof. Morgan, Prof. Bala.
Good morning.
Nice meeting you
Good
again. Yeah.
Good
So-
evening.
Yeah. So yeah, we just finished the retinal clinic, Prof. Chandra here. Yeah.
It's always busy there, isn't it?
Yeah.
Lots of interesting cases, actually.
We
Yeah.
we have about almost 100 patients today for the retinal clinic.
That's a busy day.
Yeah, it's busy.
Lots of diabetes, I bet.
Yeah, we have many patients with the RD, with the diabetic.
Oh, yes.
Yeah. That's our top number 1 and second place. Yeah.
Very advanced disease as well. I enjoyed coming there because you have a very interesting set of patients that you operate on. So it's very challenging, that's for sure.
Yeah. Okay. So I hope this evening we have more knowledge about the RD from you and also from the case. Yeah.
Excellent.
So we can learn more about the RD, especially in the rheumatogenic retinal detachment.
Yes, that's all I'll talk about. I won't talk about diabetic. It's too much for half an hour. We can do that some other time if you want. It's no problem.
Okay. Yes. Of course.
Yeah, you've your experience in Jakarta, Chandra, has sort of shed light on the difficulty of the patients that they have to operate on here.
Very, very interesting pathology. To put it politely, yeah. No, it's good. You do a very good job, and also you have very good technology there as well. I was very impressed. You have, the Dork vitrectomy machine. You have very good wide field microscopy to do the surgery. So you have great facilities actually, and your theatre staff are excellent. Actually, they're very well trained. So
very good.
I think.
Really good. Surgical tools.
Yeah, it's very good. It's comparable to what we have in Perth actually at the Lions Eye Institute, and we have a very high standard of surgical. Instruments and microscopes and all of that. So yeah, I was very impressed actually. Well, same with Bali as well, and Bali is very good too.
Well, Mita, do you think we should start?
Yeah, we can start. Please, Dr.
Okay.
Anggun, time is yours.
Okay, thank you, everyone. So good evening, everyone. Assalamualaikum warahmatullahi wabarakatuh. So in the next 1 hour, we're going to have a discussion here about retinal detachment. Yes, first session will be a case presentation by Dr. Dwi, our fellow. Yeah, it's about the rheumatogenius. It's maybe 1 or 2 cases. And the second session, we will listen from Professor Chandra's lectures about the retinal detachment. Okay, Dr. Dwi, please, you may start the presentation.
Thank you, Dr. Anggun. Good evening, everyone. Let me share my screen. Is my screen is clear?
Yes.
Yeah. Yes.
Okay, let me start the the presentation. Good evening, everyone. Good evening, Prof. Bala and Dr. Anggun as a moderator today. Thank you for the opportunity to present today in this Australian-Indonesian joint lecture series. My name is Dr. Dwi Aprina. I am a retina fellow at Cipto Mangunkusumo Hospital, University of Indonesia. Today, I'll be presenting a video case on the surgical management of rhegmatogenous retinal detachment, followed by a discussion. Today, I have two cases prepared, but I'll focus primarily on the first case today. Let's begin with case one. 58 years old male, Mr. Chiwi, who presented with a rhegmatogenous retinal detachment of the right eye with macula on and with PVR grade B. The operating surgeon was my moderator today, Dr. Anggun Ramayudanta, specialist mata ophthalmologist. Okay, this is the first Mr. Chiwi was referred from a peripheral hospital with vitreous opacity in the right eye. He reported a sudden onset of a complete shadow across his visual field, which began 3 weeks prior while he was physically active. He had long-standing floaters but denied any photopsia or history of trauma. He is myopic and wears spectacles. Importantly, he has a significant cardiac history. He has a coronary artery disease with a stent in place and he's on aspirin. This become relevant later in our anesthetic and surgical decisions. On examination, the visual acuity in the right eye was 2/60 with normal IOP. The left eye was normal at 6/6. On fundus examination of the right eye, we found a waist ring and there is a vitreous haziness grade 1. From fundus photograph, we can see that there is multiple retinal tears in superotemporal quadrant and corresponding to retinal detachment, but critically the macula was still attached and still on. So for this patient, we assess with rhegmatogenous retinal detachment with macula still on with BVR grade B, and we plan for pars plana vitrectomy plus endolaser and silicone oil under MAC anesthesia or local anesthesia. Okay, moving to the surgery, we did the surgery a week after the patient came to the polyclinic. We use a standard 23 gauge 3/4 vitrectomy. After cord vitrectomy, the fundus was examined and we found that there is 2 primary breaks were confirmed in the superotemporal quadrant at 10 until 11 o'clock and 6 until 8 o'clock. We did peripheral vitrectomy and we didn't need a retinotomy for this patient. After that, fluid air exchange was performed, retina was flattened, and we did endolaser and give a silicone oil for this patient. Before I play the video, I'd like to note that unfortunately, the initial portion of the recording about VVD induction, cord vitrectomy, and break identification was unfortunately unavailable due to a technical recording issue. And I continue for the video. Okay. Okay, to summarize what happened before, this case was operated under local anesthesia 23 gauge system. The VVD was induced, the cord vitrectomy complete, and we found that there is 2 primary breaks identified at 10 until 11 and 7 until 8 o'clock positions. The video picks up from the fluid air exchange phase. You can see the fluid air exchange is being initiated. This case was initially performed by the retina fellow on duty. However, during the fluid air exchange phase, there is some accidents. Retinal hemorrhage was encountered, yeah, which you may be able to, you can see on the video. At this point, the procedure was taken over by consultant. Our consultant tried to evacuate the hemorrhage. Evacuation was not achievable intraoperatively. But we note that the blood located far away from the macular area, and therefore the decision was made to leave the residual hemorrhage in situ, because of if we did a forced evacuation in close proximity to the macula carries a significant risk of iatrogenic macular damage. The fluid exchange was then successfully complete, and the retina was confirmed to be fully flattened prior to proceeding with endolaser retinopexy. And as you can see, the endolaser is being applied systematically around each of the break, because this case involved multiple breaks in the superotemporal quadrant. We took particular care to ensure that every break was completely surrounded by a confluent laser burns with no skip area. For prevent a redetachment of the patients. You'll notice the laser is being applied in 2 to 3 continuous rows around each break, creating a strong chorioretinal adhesion barrier. The endpoint, we are looking for a grayish-white burn. That means adequate uptake without being excessive, as overtreatment can paradoxically stimulate PVR for the patient. The laser setting here are kept moderate, 160 milliwatts with 250 millisecond durations and 200 millisecond in interval. In total, approximately 1,052 laser shots were applied across all break sites. This is the second break. We did same. We did the endolaser photocoagulation for the patient. We also extended the laser to the edges of the detached area along to the vitreous base, given the presence of PVR grade B to provide a more secure barrier circumferentially. After we ensure that all of the break are already applied to endolaser, we give a silicone oil injection for this patient. We choose silicone oil 2000 centistokes, was then injected as our tamponade agent of choice. After we think that the tamponade was enough and the intraocular pressure was firm, we stitch the sclerotomy using 8.1 Vicryl and give a subconjunctival antibiotic injection was administered. Okay, post-operatively, day 2, the eye show expected findings. There is a lid edema and spasm. There is a subconjunctival bleeding in superior nasal temporal, but parenchyma is intact. The cornea is clear. The anterior chamber deep with minimal cell and flare. From the vitreous, there is a slightly hazy, but the retina attached, the macular is still on, and silicoid in situ. From the visual acuity is stable, remain at 2/60, and the IOP is slightly low at 6. The patients placed on the face down positioning and given antibiotic and antibiotic topical and steroid topical, and we plan silicone oil removal in 3 to 6 months. Now we move to the discussion. Maybe the first question is why did we choose pars plana vitrectomy over scleral buckle for the patient? There were 4 main reasons. The first, he's an older myopic patient where buckling carries higher risk for the patients. The second, he had a multiple breaks that better access via vitrectomy than buckling. The third is because the patient has a VVR grade B that requires silicone oil tamponade, not achievable with buckle alone. And fourth is his cardiac history, so we preferred local anesthesia than general anesthesia for the patient. The slide highlights what I think is the most valuable learning point of this case, which is the intraoperative complication were encountered. As I mentioned before, the initial steps and the with air exchange were being performed by the retina fellow 1 to T. During the with-or exchange, a retinal hemorrhage was encountered. This is a recognized complication and it can occur for several reasons. At this point, our consultant took over the case. Our consultant attempted to evacuate the hemorrhage. However, unfortunately, the complete evacuation was not achievable. And here is the key decision point. The bleeding was located in the periphery away from the macula, so we had to weigh two options. The first option is aggressively pursue complete evacuation or just accept the residual blood and protect the macula. And for this case, we choose the latter. The reasoning is that forced evacuation of blood near or under the macula carries a real risk of iatrogenic damage, including RPE injury and even macular hole formation. Since as we know that evacuation outweighs the benefit. Take-home message here is, for me, especially as a fellowship, is that leaving non-submacular blood can be a deliberate and considered surgical decision. Sometimes the safest course of action is restraint. Macular safety takes precedence over achieving a perfectly clean surgical field. Following this, the fluid air exchange was complete, the retina was confirmed to be fully flattened, and we proceed to laser and silicone oil as planned. This slide addresses our choice of tamponade, specifically why we selected silicone oil 2000 for this case. Let me first walk through the tamponade option available to us. For simple retina detachment without PVR, air, or short-acting gases like SF6 may suffice. SF6 provide about 6 to 8 weeks of tamponade suitable for a single break and phakic patient. C348, a longer acting gas, lasts 8 to 12 weeks and is useful for more complex breaks. In this patient, we choose silicone oil, on the other hand, provides extended tamponade, typically 3 to 6 months, and is our preferred choice in case with PVR, traumatic detachment, or when prolonged support is needed. Why silicone oil over gas in this case? The main reason is the presence of PVR grade B, and as we know that PVR carries an elevated risk of redetachment due to a membrane contraction, and silicone oil provides more reliable, sustained tamponade compared to gas in this case. But now the more specific question, maybe why we choose 2000 centistokes rather than 1000. The key difference is viscosity. The 2000 centistoke oil has a higher viscosity, which translates to a slower rate of emulsification. We know that emulsification is one of the main long-term complications of silicone oil, and slower emulsifying oil gives us a longer, more stable tamponade window for this case. In this patient, we also plan removal at 3 to 6 months, removal of the silicone oil once the retina is confirmed stable. This is not only allow us to reassess the patient's true visual potential after oil removal, but also avoids the long-term complication associated with permanent oil retention, such as emulsification, secondary glaucoma, and keratopathy. So in summary, silicone oil 2000 centistokes was chosen for its reliable tamponade in VVR, its lower emulsification, and its removability. The final slides brings together the prognostic factors for this case and the evidence that supports our management. The single most important prognostic factor here is that the macula was attached at the presentation. In rhegmatogenous retinal detachment, macula on status is the strongest predictor of good final visual acuity because once the fovea detach, photoreceptor degeneration begins and visual recovery becomes far less certain. What is particularly interesting in this case is that the macula remains attached despite a 3-week history of symptoms. Normally, we'll be concerned that the detachment of that duration would involve the fovea, but in this patient, it's still attached. Then maybe the likely explanation for that is the anatomical location. As we know that there is a break and detachment at the superotemporal, and if the patient in upright position, gravity has keeps supraretinal fluid away from the macula, so the location of the break work in the patient's favor. Currently, at postoperative day 2, his vision remains 2/60. This is entirely expected with silicone oil in situ, as we know that the oil itself alters the eye's refractive state. We anticipate visual improvement after the oil is removed at 3 to 6 months. So overall, the expected outcome for this patient is good. To conclude this case and for take-home message, I'd like to leave you with the macula on status at presentations remain the single most important determinant of visual outcome in rheumatogenic retinal detachment. So prompt recognition and timely surgery combined with sound intraoperative decision-making gave this patient excellent chance of visual recovery. I'd like to thank my supervisor and the team. Thank you for your attention, and I welcome any question. Thank you. Thank you, Dr. Anggun.
Yeah, thank you, Dr. Dwi. It's very interesting case, yeah. So it's a patient with a retinal detachment, and it's a phakic patient, and it is on the right eye, and the retinal break is also in the right, the temporal side, superior temporal side. So I think it's will be a little challenge, yeah, it's a challenge to surgeon that have a right-handed persons. Actually, for the fellows or for the beginners that start using their left hand. Okay, so if there's any questions, please.
Good evening, Dr. Anggun. I'm Nadia from third stage of retinal division.
Yeah, please.
Okay. Thank you, professors and doctors. And thank you, Dr. Dwi, for the amazing presentation, Doctor. I would like to ask, Doctor, this detachment in the patients had been present for about 3 weeks, yet the macula was still attached. What is the factor that influenced why the macula might have been spared for so long, Doctor? Maybe can you explain? Thank you, Doctor.
Okay. Yeah. Thank you, Dr. Anggun. Thank you, Dr. Nadia, for the question. We believe that the macula was spared because of the location of the break and the detachment. The break was in the superotemporal quadrant, so the detachment originated superiorly. So as I told before, in the patient, we know that most of them are in upright position, and in the upright position, gravity tends to pull the supraretinal fluid downward. But because the fluid was tracking from a superior break, it had to spread against gravity to reach the macula, and it makes this slower progression of fluid toward of papilla and help keep the macula attached even after 3 weeks of the symptom. And this is actually a well-recognized pattern. Most of cases that I ever found that superior detachment can sometimes progress more slowly toward the macula, whereas inferior detachment, although slower to develop overall, can be more insidious. So in this case, the anatomy of the break and detachment work in the patient's favor and gave us a window to operate while the macula was still on. Thank you, doctor.
Thank you for the explanation, Doctor. So the location of the anatomical break was the supporting things that make these patients progress slowly to have the macular of the doctor. Thank you so much for the answer, Doctor.
Yeah, okay. So the attachment of the macula is still attached after 3 weeks of detachment. Yeah, that's the question. Yeah. So sometimes the clinical, we judge by clinical features, the macula still attached. But sometimes when we use the OCT, there's a substance as a subretinal fluid already there. Yeah, but because it's very few, very small fluid, so it doesn't impact the vision. Yeah. And usually when the break is on the superior, the fluid will come fast to the macula. Yeah, it will go down to the macula fastly. maybe this patient still have a good vitreous. So the tamponade still work. Yeah. That's why maybe there's why even after the 3 weeks of the symptoms, the macula is still attached. Okay. Yes, I think this Dr. Andita here. When do you decide to actively treat or drain submacular hemorrhage? And when do you choose to observe and leave the submacular hemorrhage? Okay, Dr. Dwi, there's a questions from Dr. Dita. After this, Dr. Tasha, right? Please, Dr. Dwi.
Okay, thank you, Dr. Andita, for the question. There is a very valid concern, I think, when for these patients, the submacular hemorrhage is far away from the macula. So, as we know that if there is a subretinal blood can be under the macula, it can be toxic to photoreceptor, and it can, especially under the fovea, where iron and fibrin can cause direct photoreceptor damage. So for the case, maybe we have to evacuate the blood, but for this case, because we choose to observe and leave because of the hemorrhage is far away from the macula, and if we try to have a forced evacuation for the blood, it can make iatrogenic and make a macular hole formation for the patient. I think that's the question. Maybe Dr. Anggun as operator can give an explanation.
Yeah, so yeah, if happens, the bleeding comes subretinally, then we try to take it out. Yeah, but if it's only small blood, so we can leave it. Yeah, because maybe if we try too hard, we can make another blood there. There's a bleed. When we try to take the blood, we can touch the RPE, and there's more blood there. So I think if there's only small blood, we can leave it, and at least we can do the laser retinopexy we can do, so it's okay. Okay, so I think yes, this is I think we should go to the next session, yeah, and the questions will be Dr. Tasha. You can write down the questions here.
Oh, okay, doctor. I'll write down.
Okay, yes. And we will discuss after the lecture. Okay, now I think the second session is about the lecture from Prof. Chandra.
Hi, everyone. How do I bring the talk up? Do I just go to screen share, do I?
Share screen.
Okay, sorry, just give me 1 second. I'm trying to find it. Okay. Good. Can everyone see that?
Not yet.
Not sorry.
Okay. How about now? Can you see that?
Not yet, Prof.
Okay, sorry. See, it's saying for me that the screen is being shared. You can't see it though.
Okay. It's not. You can see now.
You can?
Yeah.
Yes?
Yes.
Okay, excellent. Thanks. Okay, good evening, and thank you for inviting me for the series. I was asked to speak about retinal detachment, so I'll speak about regmatogenous retinal detachment because you all know there's different types of retinal detachments. There's serous detachments. There is, tractional retinal detachments. But I'm going to talk about rhegmatogenous detachments. Just one of the things in Australia, there's a lot more vitrectomies being done than ever before. So I just want you to be aware of that. And I'm pretty sure it's the same in Indonesia. I'm going to talk to you. I edited this talk, and sorry, it didn't save, but I'm only going to talk about 3 parts to this talk. I'm going to talk about vitreous aging, because it's very important to understand that if you're looking at retinal detachments. I'm going to talk about technical parts of vitrectomy surgery and just go through some of the things that Dr. Preena covered in her case. And then I will talk about retinal detachment. I'm not going to talk about surgical diseases of the macula. So I just want to start with aging of the vitreous. If you, this is very important, and most of the registrars and trainees in Perth really don't understand this. And a lot of my fellows actually have very little knowledge on this. And I think if you're going to be a vitreoretinal surgeon, you have to understand this. So, we all know that the vitreous changes structure as we get older. So when we're young and we're 20 years old, the vitreous is a very solid jelly structure. But then as we get older, it'll start degenerating. By the time we get to 40 years of age, you get lacunae or cavitations forming within the vitreous. And that's when a lot of patients start presenting with floaters. So that's when the vitreous syneresis starts. Around the age of 55 years or 50 years, depending on your refractive error, most people will develop a vitreous detachment, a posterior vitreous detachment. And this is a change in the eye that predisposes you to a retinal tear, vitreous hemorrhage, and retinal detachment. It's really important to remember that vitreous detachment occurs in stages. So a vitreous detachment can happen over 2 weeks, it can happen over 3 months, it can happen over 12 months. And there are different stages to a vitreous detachment. The first part of the vitreous detaching is when it detaches from the perifovea. So it's still attached to the central fovea, but that's what's called a stage 1 vitreous detachment. The stage 2 is when it detaches from the fovea and detaches out to the mid-periphery. Stage 3 is when it's detached to the periphery, but it's attached to the disc. And stage 4 is when you have a total vitreous detachment. Okay, so that's when you see the Weiss ring. So when you see a Weiss ring clinically, to me, that's usually a good sign. That tells me that the vitreous detachment has almost always completed. And when you see a Weiss ring and you check the peripheral retina carefully, and there are no retinal tears, then the chance of that patient developing retinal detachment is virtually 0%. So a Weiss ring is very important to identify. Sometimes you won't see it. And if you don't see it, then you may want to review the patient again, because you can assume safely that the vitreous hasn't completely detached. Now that we have OCTs, it's much easier to look at the vitreous, actually. So when I see patients that present with flashes and floaters, and in the retina clinic, we see lots of those patients. One of the first things I look at is the OCT. Because if you look at this OCT, you can see very clearly that the patient doesn't have a total vitreous detachment. Okay, you can see that the vitreous is detached from the perifovea, but it's still attached at the central fovea. And you can see some of the structures in the vitreous cavity, like the lacunae. You can see the premacular bursa. So these are all normal anatomic compartments within the vitreous. What I tell my fellows is you have to understand the vitreous detachment, because that will determine the pathology that you're dealing with. So when you look at macular pathologies, epiretinal membranes, vitreomacular traction syndrome, and macular holes, those conditions happen during stage 2 vitreous detachment. It's pretty logical. The vitreous is trying to separate from the fovea, and if it pulls too hard on the fovea, it'll induce a macular hole, or it may lift the outer fovea to cause vitreomacular traction that requires surgery. Okay, so that's stage 2. If you're looking at stage 3 and stage 4 vitreous detachments, that's when you can get the retinal tears because as the vitreous is separating from the peripheral retina, you can tear the retina, you can get a hemorrhage from the tear, or it can progress to a retinal detachment. So nowadays that we have the wide field OCTs, it's much easier to appreciate some of these changes. Of course, you can also look at the vitreous with ultrasound. And when you look at this ultrasound, you can see that, the vitreous is separated from the retina, but the retina is not actually detached. But remember that B-scan ultrasonography, the resolution is nowhere near as good as an OCT. So most OCT systems, the axial resolution is about 6 microns. If you're looking at an ultrasound B-scan, it's 50 microns. So there's a several magnitude difference. So really important to understand the vitreous. Now I'm going to talk to you about vitrectomy surgery now, because that is the most common operation we would do to treat a retinal detachment. And I'm going to talk about, the way we do it in Perth, or the way I do it in Perth anyway. So the vast majority of my operations I would do under local anesthetic with sedation. Okay, I think most of the operations now don't require a general anesthetic. When you do a local anesthetic, it's much better for the patient and it's a much quicker recovery. And also, in most ophthalmology operating lists, we have lots of patients that we have to do, and adding a general anesthetic to the list adds a lot of time. Okay, so most of the time it is unnecessary. I like to do a peribulbar anesthetic because you don't get a subconjunctival hemorrhage, which can then stain the cornea and then limit your view. So I personally find a peribulbar anesthetic works well. I would do a general anesthetic about 10% of the cases. So these are patients that I think are going to have a long operation. If they have PVR detachments, they need a scleral buckle. A scleral buckle is a painful operation to do under local anesthetic. So I almost always do a general anesthetic for that operation. And of course, if the patient is young and anxious, and I don't think they're going to tolerate a local anesthetic, I would give them a general anesthetic. So remember, for most vitrectomies now, the surgical time is about 30 to 40 minutes. It's pretty fast. So most of the time we don't need to admit them for an overnight stay, and we can do this under local anesthetic and sedation. For the registrars, it's important to understand what a vitrectomy is. So remember how I spoke to you about the vitreous. It's not a liquid structure like water. It becomes more liquefied as you get older. But because it's a semi-solid structure, particularly in younger patients, you have to cut the vitreous before you suck it out of the eye. And this is a vitrector in a pig. So you can see that there's a guillotine, which is cutting the vitreous, while at the same time it is aspirating the vitreous out of the eye. Okay, so that's how a vitrectomy works. Because if you put a vitrector into the eye and just aspirate without cutting it, then there's a very high chance you're going to end up with a giant retinal tear. Because the vitreous is very firmly attached to the peripheral retina along the vitreous base. So if you just pull the vitreous, then what's going to happen is you're going to pull the retina as well. And then you're going to end up in this sort of a scenario. So a vitrector is something that you cut and something that you suck at the same time. So what I think is interesting is how much the technology has progressed over the last 50 or 60 years. So this was a video I found on the internet, which is actually the first video of a vitrectomy. Okay, so this was described by Robert McAmer in Florida in the United States. This was published in 1972. So I just want to show you this video. So look at how big the instrumentation is. So this is even bigger than a 20 gauge system. I mean, this must be something like a 14 or a 16 gauge system. And look at how big the vitrector is compared to the retina. So, things have definitely improved. And with this sort of a system, there were a lot of iatrogenic breaks during the operation, and they could only deal with certain pathologies. Back in the early days also, they didn't have tamponade agents. They didn't have heavy liquid the way we do. So if they had to do complex retinal detachment surgery, very often you'd have to use these Freeman and Scapins inversion tables and actually operate with the patient upside down, particularly if you were treating something like a giant retinal tear. So, because there's been such major advancements in the technology, the outcomes have become much, much better, and the operating times actually have also reduced. So, I showed you what they did in the 1970s, so I'll show you what we do now, which everyone in the panel is very familiar with. So now we do what's called transconjunctival sutureless vitrectomy, and over the past 20 years, the size of the instruments have continued to decrease. It's gone from a 20-gauge system now to a 27-gauge system, and the 27-gauge system is about 0.4 millimeters in size. Let me just show you the comparison between the two. At the top is the vitrectomy done by Robert Mackimer, and at the bottom is the vitrectomy, the 25-gauge system that we use now. So, the one thing that I feel has really improved outcomes is the wide field operating system. And you certainly have a very beautiful operating microscope in Jakarta and Bali when I visited. And I think that really makes a very big difference to how we do the surgery in being able to visualize the peripheral retina. And, there's a much lower risk of missed breaks and redetachments because of that. So to me, the small gauge vitrectomy systems combined with the wide field operating systems have really been the two major breakthroughs for what we do. Now, this is a 27-gauge vitrectomy. For the registrars that's on the call, we call it transconjunctival sutureless because you literally pull everything out of the eye and you don't have to do anything. You don't need to use any stitches. Well, sometimes you do if the wound is leaking, but the vast majority of the patients, after a week, you don't even know that they've had an operation because the incisions are so small that the eye just heals remarkably well. So that's what transconjunctival means, and it's sutureless. Some aspects of care after a vitrectomy operation for a retinal detachment. So, Dr. Aprina went through the different tamponade agents. In Australia, I think the patients present much earlier with a retinal detachment than they would in Indonesia. I think in Indonesia, it's not uncommon, when I was there anyway, to see patients that had a retinal detachments or they had symptoms for more than 2 or 3 weeks. And because of access, getting to the hospital and those sorts of things, they present quite late. So it's very common to see PVR. So in those sorts of situations, you will often use silicone oil. But for me, in Australia, because they're presenting early, I would say for more than 95% of my cases, I would use gas tamponade. Okay. So with respect to that, Dr. Aprina went through the different gas tamponades. There's basically SF6 gas and C3F8. And I tell the registrars that, it's easy to remember. SF6 gas stays for 2 weeks, C3F8 stays for 2 months. Basically, that's how you can remember it. Silicone oil is good if you have a complicated retinal detachment, but I really don't like using silicone oil because of all the toxicity issues that Dr. Aprina outlined. But also, if you put silicone oil into the eye, you have to do another operation to remove it. So, silicone oil is committing the patient to 2 operations, and it's always better to do one if you can. Okay, so remember, there's different types of gas tamponades. Really important to remember that when we put gas into the eye, it will expand if you go up in altitude. So it is not uncommon in Perth for patients to present with a retinal detachment and to be booked for a holiday in the next week where they have to fly somewhere. So one of the first questions I ask as part of the consent is whether they've got any holidays planned, because if I'm going to put gas into the eye, they absolutely cannot fly until the gas is absorbed. So it's very important to understand that, okay, because the gas will expand, and I've certainly seen cases when, patients forget that they shouldn't fly, they get in an aeroplane and the gas expands, the pressure goes up to 80, they have a central retinal artery occlusion and they go blind. So, I've definitely come across cases like that. Whereas with silicone oil, the silicone oil doesn't expand, as you know. So you can fly the next day if you wanted to with silicone oil, but with gas, it's a different story. And I think in Indonesia, where you have, mountains and those sorts of things, it's something you also would have to be very aware of for the patient in terms of what tamponade that you use. Post-operative care after retinal detachment, I usually do face-down posturing only for one night. And I know that when I visited, most of the surgeons there were quite surprised. Most of the, in Indonesia, as I understand it, people posture for 1 to 2 weeks after retinal detachment. I personally don't think that's necessary. I think that if you have released all the traction from the tear and that you've got a good laser around the tear, then basically all you have to do is posture them until there's no fluid around the tear and the retinopexy can take hold. And remember, laser retinopexy takes hold over 48 hours. Cryotherapy takes hold over 1 week. So with laser, it's really not that important to posture after, 1 or 2 days, because the laser scar would have formed by then. The retina is sealed. Cataracts are very common after vitrectomy surgery, particularly in phakic patients, but they recover. So you'll see this gas cataract, you'll see this posterior subcapsular opacity very often after a vitrectomy, particularly if it's a long case, but after a few weeks it will be gone. But remember, most patients after a vitrectomy will need cataract surgery within 12 months. So that's also part of the consent process. And for me, eye drops after vitrectomy, I usually use it in a very similar fashion to cataract surgery. Usually they need drops only for 4 weeks. After 1 week, I stop the antibiotics and I stop the mydriatics, and they're just using topical steroids for a month. Okay, so the post-operative recovery is very quick. So let me move on and talk about acute retinal detachment, okay? Because so I've given you the background about the vitreous, how it ages, how it predisposes to retinal tears and detachments in some people. And I've also spoken about the instrumentation that we use and the advancements in the field. Okay, so what is an acute retinal detachment? Again, I do think there are differences between what we see in Australia and what you may see in Indonesia in terms of the acuity. But most of the times, in Australia, it's because they present within 24 hours with a field defect, flashes and floaters. That's a very common presentation. Now, this is a question you could ask your fellows in Indonesia, and I'd be surprised to know how many of those will actually get this question correct, because none of my fellows know the answer to this question when I ask them at the beginning of their fellowship. So what are the 3 factors that you need to form a retinal detachment? Okay. Well, this is important. This tells you whether you understand the physiology of the eye or not. The first thing you need is a full thickness retinal tear. So that allows passage of vitreous under the retina. And remember, the more liquefied the vitreous is, the easier it is to pass into the subretinal phase. So the first thing you need is a tear. The second thing you need is the vitreous still pulling on the anterior part of the tear and lifting the retina. And the third thing you need is a liquefied vitreous. So one of the questions that was asked when Dr. Prina presented her case was, why do some detachments progress quickly and some progress slowly? One of the reasons actually is also because of the state of the vitreous. So the more liquefied it is, the quicker it'll pass into the subretinal space and the faster it will accumulate. So in a patient that's 85 years old with a retinal tear, they will have a much more rapid progressive retinal detachment than someone that's 50. And that's because of the vitreous. The vitreous has changed structure. The vitreous in an 85-year-old is more like water. The vitreous in someone that's 25, 35, as I showed you, is a much more jelly substance. So it doesn't accumulate so quickly in the subretinal space. So those are the 3 things you need for retinal detachment, because we see this all the time. We see patients that have a retinal tear, but they don't have a retinal detachment. And that is because they only have a full thickness retinal defect. they probably don't have anterior traction and their vitreous may not be that liquefied. So these patients are easy. They don't need surgery. We just laser them in the clinic and they do really well. Okay, so just remember that the vast majority of retinal tears actually won't develop into retinal detachment because those three conditions aren't being satisfied. So this is a retinal detachment. I think your case is very similar to this, Dr. Aprina. This is a supranasal retinal detachment. You can see a big horseshoe retinal tear, and then you can see a bullous detachment, and the blue arrows I'm showing is the limits of the fluid. And as you correctly said, the most important determinant of a long-term visual outcome is detachment of the macula. And, you know, one of the comments that was made was clinically sometimes we look at the eye and we don't think the macula is detached, but then when you do the OCT, you see that there is a very shallow elevation of the macula due to subretinal fluid. Okay, but that's the number one thing, is not how long the retina has been detached, but whether the macula is detached or not. So when we talk about retinal detachments, I say, well, they need to be referred within 24 to 48 hours. If they have a macular retinal detachment in Perth at the Lions Eye Institute, we will probably operate on that day and fix it, or the next day at the very latest. We wouldn't leave a macular retinal detachment for a very long time. On the other hand, if you have a macular off retinal detachment, you can leave that for about 3 days, and it's probably not going to change the outcome significantly. Okay, so with the macular off retinal detachment, you have a lot more time. So just going back to the beginning of this talk, when I spoke about the vitreous detachment, when you have a retinal detachment in someone that's over the age of 45, they will almost always have a posterior vitreous detachment to account for this. So let me go through the steps of a retinal detachment. I think you showed that very nicely in your case, Dr. Aprina, but I'll go through it again anyway. So this is basically a core vitrectomy being performed, and this is really just removing the bulk of the vitreous from the peripheral retina. And when I do this, I do it under scleral depression. Now, at this point, you can see that there's a horseshoe retinal tear, and we're just removing the subretinal fluid and doing what's called a fluid-to-fluid exchange and reattaching the retina. Now we're doing an air fluid exchange, and instead of balanced salt solution, we're putting a gas bubble into the eye, that surface tension, and we're applying laser retinopexy, very similar to what you did there under scleral depression. Okay, so core vitrectomy, air fluid exchange, laser, and then we do the gas at the end. So this is a patient very similar to your case, macular retinal detachment, presents with 2 days of vision loss, but there's a very large horseshoe retinal tear. They had a vitrectomy. I drained actually through the retinal break using heavy liquid to protect the macula. And, you know, this is a very good outcome. So after 1 month, they're still seeing 6 on 6. You know, they'll eventually get a cataract because they're young, but their retina is, you know, they'll have a very good outcome. So a macular detachment is like that. So what about this case? This is a little bit different. You know, you can already see here that the patient is young. They're 52 years old. And, you know, they've lost vision over a week. I did exactly the same operation. Okay, I did a vitrectomy operation, and I used gas tapenade because it was an acute retinal detachment. But this is what happened once the gas left. So a month later, the retina has redetached, and the detachment is far worse this time than it was when they presented. So what is the cause of this? So the most common cause of retinal redetachments is PVR. Okay, so this is a very extreme case of PVR, and PVR is something that is not the surgeon's fault. It's very unpredictable, but it typically occurs in younger patients. You know, the risk factors for PVR for retinal detachment is age, so the younger you are, if you're a male patient, if you smoke, if you're aphakic, if you have lots of retinal tears, and if they're large retinal tears. So they're the main risk factors for PVR. PVR typically occurs around 6 to 12 weeks after the operation, This is very aggressive PVR that occurred very early. And this patient had a very poor outcome. I had to do 4 or 5 surgeries to reattach the retina on this patient. If you go on our audits at the Lions Eye Institute, we would say 90% of retinal detachments can be fixed with one operation. Okay, so 10% of patients will require more than one surgery. They may need a sclerobuckle, they may need a retinectomy, they may need silicone oil. But the vast majority of cases do well. So we're pretty proud of that statistic. I'm going to just shift gears a little bit and talk about a different type of retinal detachment, also rhegmatogenous. So this is a different type. This is the type of retinal detachment you will all see commonly as well. So this is an asymptomatic patient that's known to have a retinal detachment. But the difference here is that the patient is very young. They're 42. So remember, when the younger you are, the less likely you're going to have vitreous detachment. So this is a different type of retinal detachment due to round holes. This is not due to horseshoe retinal tears. Okay, so round hole retinal detachments, you can all see the holes there. I've highlighted it there for you. The holes are very different to a horseshoe retinal tear. Okay, and I'll talk to you about that in a minute. This is the OCT for the patient. The macula is, the fovea is not detached, but there is fluid at the inferior macula. Okay, so the fovea is, that's why they're seeing 6/6. But look at this OCT on this patient. Remember how I told you at the beginning of the case, one of the first things I look at when I see these patients is their OCT. So in this particular patient, there is no vitreous detachment. So this is a different type of rhegmatogenous retinal detachment. This is very different to the cases I've shown you. This is the sort of retinal detachment you would consider doing a sclerobuckle. So when I train my fellows, I would tell them that if you have a retinal detachment due to a round hole without a vitreous detachment, then those patients should be treated with a sclerobuckle, not with a vitrectomy. Okay, so that's a very important point that I want you to remember from today's talk. Not all retinal detachments require a vitrectomy. A sclerobuckle operation is very different. This is something I took from the internet, but it's a much more invasive operation than a vitrectomy. So this involves, doing a 360-degree peritomy to expose all the rectus muscles. So it's a much more painful operation. We would sling the muscles with muscle hooks and sutures to secure it. Again, very painful if you were going to do this under local anesthetic and sedation. Now that we have control of the rectus muscles, we can pass the sutures to secure the buckle to the wall of the eye. Okay, so this to me looks like a Merceline stitch. I typically use 5/0 nylon. And this is a tire that's being passed through the sutures to support the detachment and the retinal break. So this is a much, much more painful operation for the patient. They have pain for 1 or 2 weeks afterwards. Their eye is swollen, the eyelid is swollen, they can't move their eyes properly. And this is why surgeons don't like to do sclerobuckles. It's a lot more work. The patient is much more unhappy because it's painful. But it is the right operation to do in young people. The chance of success with a sclerobuckle for a round hole detachment is much, much more than 95%. Okay, so it's still very important to be trained to do a sclerobuckle because, that is the correct operation to do in some patients. And that's what it looks like after a sclerobuckle. So this is the same patient. You can see that all the subretinal fluid is gone. There's the indentation, to be honest, in this case, is a little bit high. You probably don't want such a high indent because you will induce much, much more refractive error. But you can see here the round holes are supported on the crest of the buckle. So the position of the buckle is good. I don't like to do cryotherapy at all. So what I usually do is do a buckle and then I do laser in the clinic 1 or 2 months after the subretinal fluid is gone. And that's a much more gentler procedure. You don't overtreat the retina. So that's the retinal detachment summary. So within 24 hours, if it's acute, we do it in Perth. The anatomic success is 90% with vitrectomy after 1 surgery. With sclerobuckles, it's even higher if you choose the right patient. But, you know, as I said, we still do vitrectomy for the vast majority of patients. And I think that's it. That's half an hour. So if you have any questions, I'm happy to answer it.
Yes, thank you, Prof. Chandra. Is there any questions from fellows, residents here? Please. There's one question. I think it's from Dr. Tasha, yeah? Yeah, she wrote about when we have a macular on RD, but the patient needs time, takes time, needs time to reach the hospital. So is there any something that we can say to prevent the detachments? You know, it's more become worse. So just take the bed rest or something like that.
So that's before what we can tell the patient.
Yes.
You know, they used to patch the eye and double patch it and stop the eye from moving. I don't really think that helps in a major way. There was a study that looked at that with OCT to show how fast the fluid shifts. It does help, but it's very minimal. So I don't tell the patients to do that. Now, sometimes they present with a macular and retinal detachment, and sometimes it's hard, even in Australia, to get patients into the operating theatre because if there's lots of other emergencies and we work in a general hospital, and if we know that we can't do it within 24 hours, I will very often put in a pneumatic retinopexy, you know, a gas bubble in the clinic, just to start reattaching the retina before the operation. Now that you can only do for certain retinal tears. If you have inferior pathology or you have star folds and advanced PVR, then the pneumatic is useless. But, you know, there is a number of cases where, you know, the fluid is to the arcades and I put a pneumatic, and then when I do the surgery the next day, the retina is almost totally reattached. So the surgery is much easier and you know that the macula has been preserved and they have a very good outcome. If you go to Canada, you know, I did one of my fellowships in Vancouver. They do pneumatics all the time. They don't do, you know, they probably try and avoid surgery if they can because they have such high volumes of surgery. So if you go to Toronto, you know, a lot of their retinal detachments is fixed with a pneumatic retinopexy without even doing a vitrectomy. I personally don't think that's good. I think, you know, my personal view is if you have access to a vitrectomy, the outcomes are better and it's better for the patient because they don't have to posture for 4 or 5 days and, you know, they don't have to come in every day to have reviews. It's just a pain. So I always do vitrectomy when needed, but I will buy time with a pneumatic procedure, which works very well.
Yeah. Just ask the patient to immediately go to the hospital to have a surgery. I think, yeah.
Sooner the better. That's correct. Yeah.
Okay. Any questions from Dr. Dwi, maybe?
Yes, thank you, Dr. Anggun, for the opportunity. Thank you, Professor, for the insightful lecture. I would like to ask about chronic and recurrent retinal detachment complicated by advanced PVR, Prof. In our clinic, we often find that case. In that case, for where standard technique have failed, so we already did vitrectomy, but it's failed. We already did vitrectomy and membrane filling, but it still failed. What is your general approach for the reoperation? Do you think retinectomy or using a heavy fluid silicone oil, heavy fluid is important for the patients? Or and my second question, in your experience, what factors most influence that decision? Is a location or extent of the BVR, the number of review surgery, or the status of the fellow eye? That the most important factor for decide for your decide for the operation. Thank you, Prof.
Yeah, it's a good question. So that's one of those questions I think you can ask 8 retina surgeons and you'll get 8 different opinions. So everyone has a very different approach to that problem. So generally when I teach the fellows, and my approach to retinal detachments is you have to try and do the best operation the first time and the most appropriate operation the first time. So this is why I talk about the vitreous, because it's very important to understand the status of the vitreous when you choose what operation to do. So what I mean by that, for instance, is if I have a 35-year-old patient with a retinal detachment, I know almost 100% sure there is no PVD. So I wouldn't do a vitrectomy on that, because that is not the best operation for the patient. The best operation for the patient, even though it's going to take longer and the patient's going to be uncomfortable for a few weeks, is to do a sclerobuckle. Now, when I see a patient with PVR, almost 100% of them, I will do a buccal vitrectomy operation. Because you have to understand, when you have PVR, you get what's called retinal shortening. So not only is the retina, there's a break in the retina or multiple breaks, the retina is also shortened. And what that means is it cannot conform to the curvature of the eye. So you have to address that. And there's 3 ways you can do that. You can do a buccal, you can do a peeling, like you said, or you can do a retinectomy. A lot of the time when they present, the membranes are immature, so you can't really peel much. I don't like doing retinectomies at all. I think they're a bad operation for the eye, and I would only do a retinectomy at the very end if all the other options have failed. So the first thing I would do is do a buccal vitrectomy, and a lot of the time I don't even need to use silicone oil, because by using a sclerobuckle or an encircling band, you've relieved the shortening and the traction that the retina will reattach just with gas. So that's the first thing. And for all of my retinal detachments, I'll do scleral depression and a very close shaving of the vitreous to make sure that, we've removed all the vitreous scaffold for PVR. If there's a vitreous hemorrhage, I'm very careful about removing all of the vitreous hemorrhage as well, because remember, having blood in the vitreous is a risk factor for PVR. So I do all of that, and then if the retina redetaches again, then you have to work out why it's redetached. Now, a lot of the time you have to remember that PVR is a continuous disease that even after surgery continues to progress in some patients. You could have done a perfect operation, but then the patient develops new PVR that wasn't there during the first surgery, and that's what's caused the redetach. So in those sorts of patients, you have to work out why it's redetached. Now, if there's new membranes to star folds, you could peel that. But then in those sorts of situations, you may want to put silicone oil in during the reoperation and let the eye settle for longer. And if that doesn't work, then I would consider doing a retinectomy. But for me, a retinectomy is the last procedure I would do on an eye for retinal detachment. And, we do a lot of retinal detachments in where we work at the Lion Science Students at Charles Gardner Hospital, and I would probably only do 3 or 4 retinectomies a year. And that's because doing a buccal, peeling, silicone oil, along the way, those sort of strategies will work to reattach the retina. I went to a meeting recently in Switzerland, and there's a lot of interest now in using intravitreal methotrexate to treat PVR detachments. So there was a study that was done recently called the GUARD trial, where they gave methotrexate weekly, intravitreal methotrexate weekly after surgery for 2 months. But that didn't show a significant benefit, but some people are starting to do that anyway. I don't use methotrexate, but I think it may not be a bad idea with more evidence. Does that answer your question? I mean, it's a very long-winded answer, but there's lots of factors you have to consider when a retina redetaches. Now, if you did a primary vitrectomy and the retina detaches within 2 weeks, the most likely thing there is you missed a break during the operation. So as soon as the break is no longer supported by the tamponade agent, such as gas, the retina will redetach. But if the retina detaches, say, 2 or 3 months afterwards, that's probably because of PVR. So you can't just do a vitrectomy again and expect it to work. You have to address the shrinking of the retina. And that's where you have to think about doing a buccal if you haven't done one before, or doing a peeling of the membrane and using silicone oil. all of those sorts of things. But do the best operation the first time, because everything after that is very easy. Because if in the first operation you spend 1.5 hours doing a buckle and shaving and doing everything properly, if it reattaches, it's not your fault. And the second operation is very quick and easy, actually. There's not much thinking to be done.
Yes, thank you.
Thank you, Prof.
So, Prof. Bala, there's some questions about the inferior break.
Yes.
I think it's leading to chronic retinal detachment. So, do you still use gas or right away for the oil, silicone oil, if you find the inferior break with the PVR?
Yeah, very good question. Again, I mean, if there's PVR and there's an inferior break, I'm definitely doing a sclerobuckle for that patient as well as a vitrectomy. As I said, I don't like to use silicone oil. I think it's bad for the retina. There's a lot of problems with emulsification and toxicity and pressure and all of those sorts of things. So I really don't try. I try and avoid it. What I would do is usually encircle with a 41 band, which is a 3.5 millimeter band to support the vitreous base. And then I try not to do retinotomies where there is PVR because there's contraction of the tissue there and the retinotomy may be forced open as if the PVR contracts. So in those sorts of situations, if there's an inferior break, I use PFO, heavy liquid, during the surgery to drain through the break. Then I remove the heavy liquid and then I assess what the retina is looking like under air because with the buckle supporting it, you'll find that the traction is released and you can just put C3F8 gas in. Now, if there's lots of PVR everywhere, then I would put silicone oil in. But I'm definitely doing a sclerobuckle, even if they're pseudophakic. It's just too bad. They're just going to have to update their glasses. I don't like to use Denzeron. We have it approved in Australia, which is heavy silicone oil. Do you have Denzeron in Indonesia?
Yes, we have.
Do you use that much?
No, not that much.
Because in the UK, they use it a lot. Because in the UK, they don't like to do sclerobuckles. So for that, because my current fellow is from Moorfields in London. So, for them, inferior detachments with PVR, what they will do is a vitrectomy with heavy silicone oil and see what happens.
Okay.
But I don't like to do that.
Yeah. Okay. Thank you, Prof. Maybe time is already 2012 here, Indonesian time. So yeah, I think there's no questions. I hope there's no more questions. Okay. So yeah, I think thank you, Prof. Chandra, for the
Thank you for the invitation.
from the knowledge that we have shared with us. And I think close this meeting. Dr. Mita.
Yeah, Dr. Anggun, thank you. Usually we take a photo. Dr. Aisyah will help us just a bit to take the photo and we can close the Zoom. Please, Dr. Aisyah.
Yeah, sorry to interrupt. Thank you, Prof. Chandra and Dr. Dwi for the insightful presentation. And to all the participants, thank you for joining. Could you please turn on your cameras for a quick screenshot for the attendance, please? Thank you. Okay, I'm going to take a screenshot. Okay, 1, 2, 3. 1, 2. Yeah, I think that's all. Thank you, everyone.
Thank you.
Thank you, Prof. Chandra.
Thank you, Dr. Anggun.
Yes, thank you.